Welcome to the Pot of Inquiry, everyone, the podcast for human optimization and understanding. My guest today is Dr. Jim Marino. Dr. Marino is a retired orthopedic surgeon who started out in general orthopedics and then specialized in spine surgery. The conversation we have today talks about the evolution and improvement of spine surgery and gives you some idea of how things are today versus 20 or 30 years ago. We also talk about different bone grafting techniques, but that's a small part of the discussion. So don't worry if you're not interested in bone grafting and that. I get it, but I think you'll enjoy this conversation because you're going to learn a lot about back surgery, how the diagnosis is properly made, when to use MRIs, different types of exercises that you can use. So please enjoy this conversation that I have with Dr. Jim Marino.
Welcome to the Pot of Inquiry. Ready for some thought-provoking cerebral whipping and the destruction of ridiculous medical dogma? Want to shift those stale, moldy old paradigms? Well then, don that thinking cap of yours, get down in the cave, and join our host, Dr. Stephen Barrett, for this week's episode. Let's start spelunking.
Welcome to the Pot of Inquiry, everyone. I am here with Dr. Jim Marino. We're going to talk about some really cool stuff. One of it is going to be his bone harvesting device, and then we're going to dive into some interesting things about spine surgery. Jim, tell everybody where you're coming from. I know that you practiced spinal surgery for what, about 3 decades, 4 decades?
Yeah, I was in active practice up until about 5 years ago, but I did primarily degenerative lumbar spine surgery in the latter half of my clinical years. Prior to that, I was a general orthopedist, and I did assist other orthopedists in a variety of procedures, everything from total joints to hand surgery to trauma, and ended up sort of subspecializing in degenerative lumbar disease disorders. And I joined a group of a couple of other orthopedists and had a bit of a local referral practice based on my experience with low back treatment.
What was the draw to bring you into lumbar spinal surgery from general orthopedics?
It was really a practical matter. I trained at a time when arthroscopic surgery was really in its infancy in the early 80s.
Okay.
I finished my residency in 1984, and I thoroughly embraced and was fascinated by arthroscopic interventions and was primarily interested in advancing arthroscopic techniques in the peripheral joints, shoulder, ankle, elbow, knee, primarily. I didn't do any hip arthroscopy, although that is an area that's productive. And I was in a community situation where most of my patients walking through the door were complaining of back pain, and didn't really have any arthroscopic applications for back pain at that time. That's changed, but at the time it wasn't the case. And I had to make a decision if I was going to be just referring all these patients out if they didn't respond to conservative care, or if I was going to be a competent low back surgeon. And I decided that I would supplement my orthopedic training, which was at University of California, San Diego, with some informal but significant experience going to a variety of meetings, including cadaver sessions, and also attend other surgeons who were doing spine surgery in the community and assist them. And eventually I found myself doing a lot of back surgery, and I think I did it well. And that's an area where a lot of surgeons are hesitant to get involved. So it just turned out that that's where I was going to get most of my patients. So that's kind of how it evolved.
Well, and then once you gravitate towards something, you develop more of an expertise, and then that draws more people in that area. It just kind of, it happens.
Yeah, it is reinforcing. I I also saw that there was opportunity for enhancement that was substantially along the lines of minimally invasive approaches. And I seem to be, and I think I am, naturally inclined to innovate. I like
Right.
problem solving, and innovation is essentially just creative problem solving.
So,
And I, um, I could see where there was a tremendous need for reducing the amount of collateral injury
mhm.
associated with traditional open spine surgery, and that a variety of both techniques and instrumentation would have to be developed in that area. And I was anxious to be a part of that. And I think I did make my contribution, particularly in the area of elicited, uh, I'll say, nerve stimulation with the use of electrified catheters or electrified obturators, cannulas, instrumentation, and the like, and uh, you're looking at depolarization of the peripheral muscle groups and triggering, if you will, a response in those muscle groups, which could be detected, which gave you a sense of proximity to the nerve with your instrument when you were using minimally invasive techniques.
So let me
And
ask you, before you go on, because I think this is very fascinating, because you actually, when you started your spine practice, there was probably very little minimally invasive endoscopic spine. And then as you went along, you started developing innovation as well as
yes,
others. And then it
yes,
has
yeah,
changed tremendously.
I don't want to represent that I was the initiator. I was just one of the contributors. There were certainly some, I'll say, very prominent initiators. One in the United States, Dr. Parviz Kambin, who was an orthopedic surgeon who practiced at the Graduate Hospital in Philadelphia, Pennsylvania.
Hmm.
And I had heard that he was doing arthroscopic lumbar discectomies. And I was intrigued. So I attended a number of courses where he was giving lectures. And then I went to the Graduate Hospital to observe and to study with him for a few days and take a course that he gave on his technique. And while Dr. Kambin made an enormous contribution in the field, there was still a lot more to be done. And I had some, I think, insights that eventually became part of the field.
So the Graduate Hospital, is that where in Philadelphia, is that where Schwartzman was? The guy who took care of all the complex regional pain syndrome, or back then it was RSD?
I don't know. He
I
could
think
very
it
well
might,
have been, but
yeah,
I'm not familiar. I'm
yeah.
familiar, of course, with reflex sympathetic dystrophy in my training, but um, I didn't realize that one of the people who identified it and investigated it may have come from the same hospital. That's
I,
something new to
I,
me.
well, I know it was Philadelphia. For some reason, I'm just that association popped up in my head, and it's like a small world, but
Yes.
very interesting. So what, I mean, now they're doing almost everything from a spine surgery standpoint. I don't want to say, let's say lesser invasive methods.
Yeah.
So,
Sure. Sure.
almost,
Listen.
yeah. So, I mean, where an incision was 5 inches before, it's maybe 5 millimeters now. I mean, it's,
Well, yeah. I
yeah,
mean,
vast.
there's been a reduction in collateral damage,
Right.
denervation, muscle stripping. Uh, there are there is a field of endoscopic spine surgery which has not really taken on quite the number of surgeon advocates and practitioners in the United States as it has in Europe and in other parts of the world. Turkey's one of the places I'm aware where there's a fair amount of it. But there are surgeons who are doing lumbar decompressions for spinal stenosis, as well as obviously herniated discs, all
Mhm.
endoscopically.
Right.
And I've again I didn't practice that, but I did attend courses given by the I'll say the protagonists and advocates for that, and I do see that as being very fruitful and a rational approach to these kind of problems, and I do think it will, with time, become um, more prevalent, if not the standard of care, because
Right.
it's a very powerful tool. You can see more with an endoscope in the proper conditions than you can with the naked eye. It's basically putting your eye where the pathology is
Right.
and having it in a magnified form.
Right.
I can remember when I first started practicing orthopedics, and before I was really involved so much in spine, I was doing peripheral joint arthroscopy in the very early stages, and I was doing arthroscopic subacromial decompression procedures.
Mm-hmm.
And this was a procedure that was almost universally done in an open manner. And one of the world's authorities came to San Diego to give a lecture, and I was maybe a year and a half to 2 years post residency training, and I had done quite a few of these and realized how powerful this tool was. And this was a community orthopedic and university-based lecture, and the lecturer asked if there was anybody in the audience who had any experience or had any questions with respect to his approach to subacromial decompression. This is a Dr. Charles Rockwood, who's a very famous and very capable orthopedist, but he didn't have experience in endoscopic techniques. And I mentioned that I had been doing arthroscopic subacromial decompression, and he kind of laughed and said, I bet you can't see anything. I said, no, actually, you can see quite a bit. And I said,
Right.
you
Right.
actually can see quite a bit.
Right.
And after that lecture, some of my colleagues in the community, part in jest, but part, I think, to sort of make a point, were saying, do you really think you can see anything, Jim? Well, within, I'd say, 5 to 10 years, every one of them was doing arthroscopic subacromial decompression. It
Right.
became obvious that this was the preferred approach to the open technique. And so I think this is going to happen also more, it's taking a longer time in spine surgery, but it will happen that many of these endoscopic techniques will supplant the open procedures, particularly since we have a large number of patients who are in the older population who experience spinal stenosis.
Mm-hmm.
And the open procedure it carries a substantial amount of morbidity and recovery. And if you can do a 2 or 3 level endoscopic decompression and relieve them of their spinal stenosis or neural claudication pain, that's all they need. They don't need to have their backs filleted open, and they don't need to have, most of the time, segmental instrumentation or pedicle screw fixation infusions, which are sometimes difficult to achieve with an older population. So I think
Right.
this will gradually replace, in a large number of patients, the open techniques.
Yeah, that's really very interesting. I kind of went through the same historical pattern that you did. I developed endoscopic plantar fasciotomy in 1990, 1991.
Good for you.
And when I introduced it, people, I mean, they were very skeptical. I had a lot of arrows shot into my back at meetings,
Yes.
and then, you know, a year down the line, the people that were the most aggressive were actually taking our training courses. And so
Yes.
it kind of had this evolution. But what we saw was the fact that, we had, for, open plantar fasciotomies, and I mean, people like Joe DiMaggio were ruined by, the approach for it, not necessarily the actual technique that was done for him. But what we saw was that in patients who had had open heel spur resections and plantar fasciectomies versus an endoscopic approach, they would compare it themselves to like a rattlesnake bite compared to a mosquito bite. And
Sure.
And I would think that would be probably the same thing that you saw in your course going through your history of spinal surgery. And that leads to my question. There's this mythical number that, and I don't even know where this comes from, and it's probably not even true, but like 60% of back surgery is failed back surgery. And I don't think that's true. I mean, but I'm sure you've heard a high number, right? But that had to come down with the advent and implementation of the lesser invasive techniques.
So I'd like to say yes, but I'm going to hesitate because I want to make clear that probably the most important feature of treating a patient with back problems is, number one, identifying the pathology. What is actually causing their back pain? And it's not like you can put a finger on the pathology in the back like you can for, I don't know, a metacarpal fracture.
Right.
A patient doesn't need an X-ray to put their finger on the metacarpal that's fractured, or a foot fracture, or a painful lesion in their foot. It's just much easier for the patient to localize. And the back we don't have the neural discrimination, and it's just hard to know because it's a multi-segmented structure, and there's a lot of asymptomatic pathology, which is evident on X-ray, MRI, etc. So really, first problem with backs is getting to know and try to figure out where is the pain coming from. If it's neural or if it's structural, or is it radicular type pain, or is it a somatic pain? And then after you make that determination, which takes in my opinion, takes a careful history and physical exam. And history, probably the emphasis on the history, knowing when you get pain relief and when you get exacerbation. Then you can start looking at the indirect evidence on X-ray and MRI.
Before we continue with this great discussion, I just want to take a quick break to acknowledge this week's sponsor. I'm constantly exploring new avenues to enhance well-being and address any health concerns. Today, I'm thrilled to introduce you to an exciting supplement called Stem Regen, which I take daily and genuinely believe could revolutionize your health journey as well. Stem Regen stands out as a game changer in the realm of wellness. Crafted from 5 potent plant extracts, it boasts a remarkable ability to stimulate the release of your body's own stem cells from your red bone marrow. Why is this significant? Well, stem cells are the superheroes of our body's natural repair system. They possess the extraordinary capacity to morph into various cell types, aiding in tissue regeneration and repair. As we age, the quantity of circulating stem cells in our system reduces significantly, impairing our body's ability to heal and rejuvenate itself effectively. Stem Regen steps in to counter this decline by kickstarting the release of stem cells into circulation, thereby bolstering your body's innate repair mechanisms. Once unleashed into your bloodstream, these mobilized stem cells actively seek out areas of damage or injury, initiating the healing process. By incorporating Stem Regen into your daily routine, you're essentially empowering your body to tap into its own regenerative prowess more efficiently. I firmly believe that Stem Regen could be a valuable addition to your wellness regimen, especially if you're seeking to fortify overall health and vitality, accelerate tissue repair, or expedite recovery from injury or illness. This first of its kind stem cell mobilizer is changing the game in regenerative medicine. Don't wait to unleash your body's innate healing capabilities. Visit stemregen.co/Dr. Steven, that's with a PH, and use the code SBPOD to get a 15% discount off your first order of Stem Regen. Hey Spelunkers, We're thrilled to kick off season 6 with a fresh new look and the most exciting content we've ever delivered. This season, we're diving deep into the fascinating world of human optimization and understanding. But wait, there's more. We're giving back to our loyal listeners with an exclusive giveaway each and every episode of season 6. That's right, prizes are waiting just for you. So how can you join in on this fun? Well, it's simple. Follow us on Facebook, Instagram, and LinkedIn. Subscribe to our YouTube channel, and here's the magic touch. Comment, "Let's Spelunk" on any of our season 6 YouTube videos to enter. Of course, please add anything else you'd like to your review. Don't miss your chance to explore, learn, and win with the Pod of Inquiry. Let's spelunk into the wonders of season 6 together.
And try to identify which of the structures is causing the pain. Sometimes it's obvious, but many times it's not so obvious. And then you have to decide, okay, has this patient had an adequate course of conservative care, whether it's been properly administered or of sufficient duration?
Right.
And this is time consuming. Taking the time to properly to get the history and determine from the various radiographic studies what the pathology is and how much conservative care they've had and how the quality of that conservative care. There's a lot of hand-holding involved, and not every surgeon is that patient. And not every surgeon gives the patient enough time to optimize the care. And I would say there's a lot of very talented surgeons who want to use their talents. And so even though I think the techniques have become far more powerful, maybe the indications are not as tight as they could be in some of the surgical practitioners as they should be. And so operating on patients who don't need the surgery or not identifying the pathology that's actually causing the symptoms is probably a large reason why many of these back surgeries have failed in the past. We did not have the powerful tool of segmental fixation until sometime in the late 80s, early 90s. And that really came from Europe, from France. And Cottrell, Dubussy were really the first to really popularize the use of pedicle screws. And it's become a mainstay of stabilization for the spine and interbody fusion, as opposed to posterolateral fusion, which was fusion between basically the transverse processes. And transverse processes are small bony projections in the spine that are pretty, I'll say, relatively flimsy or fragile. I mean, you can break a transverse process with your finger pretty easily if you push on it in an osteopenic patient. But in interbody fusion, it's a very powerful tool, and we've developed a lot of techniques for achieving interbody fusions, both the use of interbody spacers and the use of I'll just say improved bone grafting techniques and bone grafting substitutes supplemented with pedicle screw fixations. So I think the chances of getting a fusion now are far higher than they used to be 30 years ago, far higher. I think fusion rates are now well above, even with using fine cut CT scan, which is not always accurate, but best we can do non-invasively. We probably are getting fusion rates at 80 to 90% or higher, whereas it used to be closer to 60% with posterolateral fusions, if it was even that high. Yeah, I think the techniques have improved the outcomes. The question is, are the indications as tight as they should be? And again, that's very, very dependent upon the surgeon and their kind of indications and philosophy about who they're going to treat.
Well, I think you made several very valid points in that description. One is accurate diagnosis increases surgical efficacy without a doubt. And you're so right. There are very technical surgeons, many different specialties, but if you have if you've identified the pain generator as something that's not really the true pain generator, the most perfect surgery in the world is not going to work.
And that's particularly easy to make that mistake in the spine.
Yeah,
It's very tough. I mean, you have a bunch of degenerative discs, and you got a patient with, mechanical back pain. They have degenerative facet joints. Where do you begin and where do you start immobilizing? Where do you stop immobilizing? And then there's also a consequence to immobilizing in the spine. I mean, you start fusing one segment, particularly if you don't fuse them in an I'll say a physiologic and anatomically proper position. If you don't reproduce the normal lordosis in this fused segment, you put additional strain on the adjacent segments, which are already degenerative. So you get what's called add-on disease or adjacent segment degeneration. It's a very common problem. And some people call it an annuity, they
yeah,
just keep operating on patients every 3 or 4 years.
right.
And, that's not a great outcome, obviously.
No, and I think that's regardless of where you're fusing things in the hand or the foot, the lower
Yes,
extremity, you have to realize that that joint had a biomechanic purpose to begin with.
of
And
course.
now we've taken that away. So something has to, the body tries to compensate, and sometimes it gets away with it pretty good, but
Yeah,
usually not. There's
yeah,
always some kind of a payback
yeah.
that,
Yeah,
but
you're talking to somebody who had a triple arthrodesis at age 12, and I'm 71 now. So
wow. So yeah. And then
yes,
I think you told me you had polio,
yes,
and that's why you ended up with the triple arthrodesis.
yes,
Yeah. Very
yeah,
interesting.
yeah. I was one of the last Mohegans. They Another very interesting topic you could probably get me to talk about at some point is the early failings of the Salk vaccine. I happen
Mm,
to know quite a bit about it because I contracted polio from a bad Salk vaccine in 1956. And the Salk vaccine, most people don't know this, but wasn't really safe for about 6 years. It took them
interesting.
6 years to figure out how to properly prepare the vaccine.
That's interesting. Yeah, there's a lot of discussion now about the testing and uh,
Vaccine safety, yeah.
yeah, exactly.
Well, I
And
mean, a lot was learned from, these earlier vaccines. Things had to be learned, and the Salk vaccine was one of the um, early, I'll say, testing grounds for vaccine preparation, and they made some honest mistakes. And I'm not faulting Jonas Salk, although some of his contemporaries did. Jonas Salk obviously won the Nobel Prize, but he was never inducted into the National Academy of Science because it was known that prior to releasing the vaccine, rhesus monkeys that had been immunocompromised with steroids were dying from the vaccine. And
mm,
his colleagues told him, it was too early not to release the vaccine, but he insisted. There was a lot of pressure on him politically.
right.
To his credit, he administered it to his children, so he did believe in the vaccine, but there were tens of thousands who developed paralytic polio from the Salk vaccine.
Yeah, that's very interesting. Well, let me go back to your triple arthrodesis. Now, did you
Sure.
personally notice any proximal disruption
Of
in?
course. Of course, my
Yeah.
ankle joint has a lot of arthritic changes and minimal movement. And were it not for the fact that my left lower extremity bears very little, I'll say, of my standing weight-bearing burden, and I put it mostly on my right lower extremity. And I'm a limited community ambulator at this point in my life. I can't walk very far, and I have, if I have to walk distances, I'll use crutches.
Mm,
So I'm really putting low demand on my
right.
left lower extremity, and because of that, even though my ankle is arthritic and limited in its motion, I get away with it. But
Right.
there's no question about it that triple arthrodesis did lead to ankle degenerative changes.
Well, let me ask you a question. I want to go back to the pain generator and identifying the pain generator, and
Yes,
this can be very difficult. And
extremely
uh,
difficult.
a lot of people think that the MRI not physicians, but the lay public, they think that the MRI just pops up and tells you all of the answers.
Yeah.
And that's so far from the truth. I mean, if you think about it, all an MRI does is it shows you a change in morphology.
Well, I like to say, I tell my patients, if you take a family photo and everybody's smiling, does that mean everybody's happy?
Right.
Just because they have a smile on their face doesn't mean they're all happy.
Or
they can
all have frowns and be happy.
Well, that's what I'm going to say is, in the case of the MRI, a lot of discs are slightly desiccated, degenerated. But if you consider how many people over the age of 60 who get put in a box and put in the ground don't have degenerative lumbar changes, probably 0%.
Yeah,
0%.
I was
so a large percentage of these people who die with degenerative disc disease are asymptomatic. Right. So we know that a large percentage of our population will have transient back pain or very little back pain, and sometimes go for long periods of time asymptomatic. But if you look at their radiographic findings or their MRI studies, you can easily make diagnoses of prolapsed disc, degenerative facet joint, spondylolisthesis. I mean, you name it. And it's been done. I mean, there have been studies that have been done which take an asymptomatic adult population and subject them to an MRI. And typically the numbers you hear, and I can't quote them exactly, but it's around 30% will have significant pathology, enough that it could justify surgical intervention. So if 1/3 of the patients who have no symptoms at all have these degenerative findings, you can certainly imagine that in a symptomatic patient population where multiple discs or facet joints show evidence of pathology in MRI, figuring out which one is causing the pain can be difficult. Sometimes you don't know.
Right.
Sometimes you just cannot know. We used to have a tool which was helpful, which was called provocative discography. And I used it before it fell out of favor. And it was a very helpful tool because you could put your finger on the disc, so to speak. You could place a needle. Let's say a patient was having low back pain on the right side, and you had two degenerative discs, L4-5, L5-S1, and you're trying to figure out, do I need to address both of these or just one?
Right.
I would place a very small needle from the left side, the asymptomatic side, into the discs. I try to go into the disc I think was less likely to be the provocateur, if you will. And I would instill a small amount of contrast material and distend the disc. And you could see a certain pattern on fluoroscopy, which would denote how much degeneration and where that contrast material was flowing. And if you would inject from the left side and reproduce their right-sided symptoms, identical symptoms, you had a very good sense that, oh yeah, this is the prolapsed or herniated or degenerative disc that's provoking the pain.
Okay.
And if you put it in and you saw degenerative changes, but there was no pain on the right side, you could say, well, it's a degenerative disc, but it's not the source of their pain. That's not why they're seeing me. And a study was done at Stanford University looking at provocative discography, and they included a control group of young, I think college students who had these provocative discograms. And somebody decided to look at that population, the control group, 10 years later or some period of time later, maybe it was 5 or 10 years later. And they had a higher than what would be expected baseline amount of degenerative changes in the discs that received the provocative discogram. So the use of provocative discography ended really for the most part then. I mean, it's still used, but it's used with much fewer indications and much less frequently. But it seemed to implicate that the discogram itself could contribute to degenerative changes in an otherwise healthy, normal person. So we lost that tool. And now you have to surmise based on symptoms and instability and, with flexion extension views and also the MRI findings as to which motion segment is producing the pain. And as I said, this is not something you can necessarily figure out quickly.
Right.
And surgeons have to be patient and exercise a lot of, I'll say, restraint before making decisions. Otherwise, they're going to be operating on asymptomatic, even though there may be degenerative, but asymptomatic levels.
So is there still utilization of dynamic fluoroscopy?
Yes.
Because I think that's a very powerful, because you can see
Yes.
what's going on versus a
Yeah. So
static
usually
image.
it's not so much that we do dynamic fluoroscopy. We just do what we call flexion extension views.
Right.
And you need a cooperative patient to do it, and it needs to be done properly. And yes, you can certainly demonstrate what is normally termed instability based upon the number of degrees of rotation and or translational movement between motion segments. And yes, that can be helpful. Again, you're demonstrating instability. That doesn't necessarily directly correlate with pain generation, but it often does.
So if we're trying to break it down for the knucklehead that I am, right?
Well, I'm sure you're not, but go ahead. How can I help you with your
But let's say, all
milestone?
right, so let's say a patient comes in and they have low back pain, and
Yes.
you look on the MRI, there is a herniation of a disc, and maybe they have a little bit of degeneration in their spine. And now a message from our sponsor. One of our main sponsors, Approved Medical Solutions, is running a 5-day cost-free study on the effects of their product Clean Ketones for essential tremors. This is going to be a very beneficial application for this product, and they have demonstrated to me that it not only improves my athletic performance by at least 10%, it also helps with clarity and concentration. So if you'd like to enroll somebody that you know into this study, just see the link below, and they will welcome you in to try this great product. Where are you thinking about? Are you thinking facet joints, spinal stenosis? Is there some spondylolisthesis contributing to this?
Okay, so again, this is where the history is super important. You got to
Right.
know the duration of their symptoms,
Right.
the severity of their symptoms, aggravating factors, relieving factors. First, I'll say this. There's a big difference between what is commonly referred to as sciatica or basically nerve root pain versus somatic pain. Annular tears. I'll start here.
Okay.
I don't think there's really any muscle strains to speak of that cause back pain. You hear that all the time. I strained the muscles in my back. I think that almost never happens. Almost never.
Right.
It's almost always annular tears. And the reason I say that is how often except in elite athletes, how often do you strain your quadriceps? How often do you strain your biceps? I mean, it
Right.
just does. The muscle doesn't get strained that often. It's rare. You may get a tendonitis in a biceps, but you may get infrapatellar tendonitis. More likely, it's the tendon. But in the back, it's not so much the muscles that get injured. And by the way, I cannot recall seeing an MRI that showed inflammation of the paraspinal muscles ever, or a tear and hemorrhage in the paraspinal muscles. I mean, that's almost a reportable case. So if all these people who are complaining of back pain are straining muscles, you would think that we would be seeing this occasionally, or edema in those muscles.
Right.
Normally, what we'll see is fatty replacement from
Denervation.
disc atrophy.
Right.
But we don't see muscle injury on MRI in virtually any patients. So I then extrapolate that back to what causes common back pain. It's not muscle injury. It's not straining your muscles. It's annular tears for the most part, not all the time, but frequently. Annular tears, the annulus is invested with nerve roots. And when we tear the annulus through disc prolapse and a variety of other causes, that's a source of back pain that can be chronic and recurrent and can lead ultimately, in some instances, to disc herniation, which can lead into sciatica or radicular pain, nerve root pain. So if a person comes in with back pain and they have a herniated disc, there's already a disconnect because I'm saying, okay, well, I can understand the annular tear, but they've got a herniated disc and they don't have any radicular pain. So now I've got to be careful here that I'm not missing something else. Maybe a level above may have an annular tear, etc. I got to make sure that I don't miss something because what's very obvious may be distracting me from the real pathology. But anyway, we'll get back to your example. How long have they had conservative care? I mean, I've had back pain periodically for decades.
Right.
And I've never had back surgery, and I'm an advocate for back surgery. And that's because I understand that a lot of these conditions are self-limiting and will resolve. Back exercises are not employed sufficiently, in my opinion, and could be done with regularity, particularly in people who have chronic recurrent back pain. There's a series of exercises your viewers might want to look up called McKenzie lumbar extension exercises.
Okay.
McKenzie lumbar extension exercises. And they're basically extension, passive and active extension exercises of the lumbar spine. McKenzie was a physical therapist, I think in New Zealand. I don't think it was Australia. I think it was New Zealand. May be wrong on that. But he had a patient, and this patient had a herniated disc. They were having radicular symptoms. They were sent for conservative treatment. And the story, as I understand it from Robin McKenzie, the person who developed this technique, was he told the patient he had to leave the patient for a moment and had to go address some concern in a different location for a moment. When he came back, he found the patient on the exam table, which had been flexed in a prone position with his back fully extended. And he thought, oh my God, this guy's, whatever his back pain was must be exacerbated by, he thought he left the patient, he was going to be sitting, or sort of reclining on this gurney or this exam table. And the patient said, this feels good. I feel better like this.
Right.
And he was smart enough to figure out, well, maybe there's something to this. And he started developing extension exercises and found that with acute disc herniations and the like, you could get the disc to reduce in a large number of patients through active and passive extension exercises.
Mm-hmm.
And they've been demonstrated repeatedly over the years to be the most efficacious form of physical therapy for disc prolapse, disc herniation symptoms. So I would get a patient frequently back pain and ask them, what kind of conservative care you've had, and they'd say, well, I've went to physical therapy, and then you'd ask specifically, well, exactly what was the physical therapy? And very often it did not include lumbar extension exercises.
Mm.
And those are exercises that the patient can do on their own, in their home, in their office, 3 or 4 times a day, not once or twice or 3 times a week, 3 or 4 times a day.
Right.
And so the first thing I do with a patient like that is, after making sure they didn't have symptoms like a tumor, or, weight loss and unexplained weight loss or fever and chills or things like that, suspicious for infection, I'd say, well, let's get you on a McKenzie lumbar extension exercise regime. I'd show them how to do it. I'd watch them in the office. And I'd get them to do it in front of me. And then I'd say, no, don't do this once a day. I want you to do it 3 or 4 times a day for 2 weeks. And your pain may get worse initially, but persist with it. And if 2 weeks, if it's not helping you, that will help me determine that, your condition is not likely to respond.
Right.
And so that would be the first place I'd start with that. And often I did not get any MRIs. I mean, MRIs are really indicated only when you don't know what's going on and you don't have a good idea, or you're suspicious of some kind of condition that requires fairly immediate intervention, like a discitis, an infected disc, or a tumor. But otherwise, why get an MRI? I mean, you're not going to operate. I mean, a lot of people came in with back pain expecting me to order an MRI.
Right.
And they were disappointed when I didn't. And I'd say, well, let's just presume for a moment I had an MRI in my hands and it said that you have a prolapsed disc at L5S1. Are you ready to sign up for surgery? And they'd say, oh, no. I said, well, then why do I need an MRI?
Right.
I'm not ready to operate on you. The only reason I'm going to get the MRI is if I don't know what's going on, but I have a pretty good sense of what's going on, so I don't need it. And when I'm ready to operate, I have to make sure I identify the level. Well, we're not ready to operate, so why waste your money and the health system's money on getting a study which is completely, unproductive? And I'm sure I lost a number of patients because of that. I mean, I can think of patients that I did eventually lose because they were disappointed I didn't get an MRI.
Right.
And but you're going to get the MRI when you make a determination that you're ready to operate and you want to be certain of the level and you want to see the pathology in an anatomic form. But otherwise, you just don't need one. And
Yeah.
it's not even clear that back x-rays are of much help, particularly when you're starting in the evaluation of the patient with back pain. So that's how I started out with most of my patients, and I think for some it may have favorably impressed them, and for others it might have been disappointing.
Well, I think, I think this is really very interesting. I want to wrap up with getting to the one thing that we haven't talked about yet, but you mentioned the efficacy of interbody fusions has, in your opinion, been drastically
Yes,
improved over the last several decades. And
yes,
you've developed the Corex bone harvester. So can you talk about that a little bit and briefly,
sure. I mean, it's a
touch on
little, it's
allograft versus autograft?
yeah, it's a little bit of an infomercial here, but
That's fine. I mean, because
that's
I
all right.
think
I
it's an
mean,
important thing.
without being too, I'll say, excessively, I'll say, advocating for my own device, I'll say this. We have over 100 years of literature review for autologous cancellous bone harvesting benefits in a variety of applications, trauma, tumor surgery, arthrodeses, etc. Autologous cancellous bone has proven itself to be extremely effective in getting bone to heal and in getting joints to fuse. And there's been an understandable interest in finding bone graft substitutes. And I'm not by any means indicating that they don't work or they shouldn't be utilized. I would just say that people should remember the gold standard because it has stood the test of time and does provide osteoconduction, osteoproliferation, and also osteoinduction. So the three elements you're looking for, osteoproliferation, osteoinduction, osteoconduction, are all there in autologous bone. And while allografts are very effective in many instances, they don't provide all three. And efforts to try to reproduce all three, which are the cell-based matrices, or CBMs, there have been a number of systematic review articles looking into CBMs, and there's no evidence that CBMs are any more effective than the demineralized bone matrix that's used as a carrier. In fact, if you look at athymic rat and mice studies, if you leave out the cells, you get better healing than if you put them in. And mesenchymal stem cells are often portrayed as being, I'll say, immunologically privileged, and they are not. And I have a number of studies to show that in vivo, not in vitro, in vivo, they are both humoral and cellularly active in stimulating immune responses from an immunocompetent host. Yet hundreds of millions of dollars are spent each year on CBMs in the United States because my colleagues have been, to the most part, they fail to be, I'll say, to scrutinize the evidence associated with them.
Right.
And there's a lot of money behind these. There's a
Oh, yeah.
tremendous amount of money to be made in basically biologics and osteobiologics in particular. And while many of them can be effective, they're not more effective than cancellous bone. And cancellous bone can be harvested in a minimally traumatic way using minimally invasive techniques like the Corex bone harvester.
Right.
I can use a Corex bone harvester and harvest from the calcaneus the proximal tibia, the distal tibia, the iliac crest, in a matter of just a few minutes and obtain sufficient cancellous bone graft, which has been minimally manipulated so that there's preservation of cellular activity and there's not significant alteration of architecture. And that can be done at a relatively low cost compared to some of the alternatives. And unfortunately, the big companies that are advocating for the biologic alternatives have been promulgating their alternatives by disparaging autologous bone graft harvesting, typically by quoting studies that show enormously high complication rates with autograft harvesting. Well, these are antiquated studies. They're very out of date. They don't apply to minimally invasive harvesting techniques. And so I would ask your viewers to consider minimally invasive autologous bone harvesting. If they want to, they can look up Corex bone harvester on the internet, and you can see videos where I harvest in patients and in cadavers, and I show how quick and effective it can be. And we don't morselize the bone. We leave it, the architecture is well preserved. It's been shown that morselization delays healing. So anyway, that's my promotional material for this interview. That I think there's been a neglect of autologous bone harvesting that should be addressed, and I'm here as promoting that.
Well, I think you make some really valid points there, Jim, because this is indicative of all of medicine right now, where things have been maligned and unfairly maligned in many ways because there wasn't a commercial drive that fit that particular paradigm. And so I think that's what happened here. It's like, oh, you can get this stuff out of a jar, it's faster and it's better and all this other stuff. And the fact of the matter is it's not. I mean, it's really hard.
It's convenient, but it isn't better. Correct.
Yeah. And the truth of the matter is that it's really hard to beat Mother Nature.
It is.
I mean, the best implant in the world for joint replacement cannot even compare to what God gave us. There's no way.
Most total joints are trying to replicate what God gave us.
Yeah, but they don't do it as well as the real deal.
Materials are different, right?
Yeah, exactly. Dr. Jim Marino, thanks so much for sharing your insight, expertise.
My pleasure.
I would say, I don't have this statistic, but I'm going to say a very high percentage of all of our listeners have interest in backs because most of us have some back pain at some time. So
correct.
Thank you.
Yeah.
Thank you very much for coming on.
Thank you for having me.
As you know, I'm passionate about learning new ways to address health concerns. Moreover, before I recommend any treatment or supplement, I always try it on myself. Today, I want to share my experience with Troche. I have investigated other phytocannabinoid formulas and found that, in general, they were not consistent or reliable in their results. What impressed me about the Troche delivery technology is that each rapid-release tab is engineered to provide fast-acting, long-lasting, reliable delivery of phytocannabinoids to support your health and well-being. Many physicians understand the importance of using phytocannabinoids for physical discomfort, sleep issues, and mood. But if the formula is not reliable, most patients will give up, never experiencing the real benefits. I put this to the test on myself and actually tracked my progress. This graph shows my results for reducing stress. Troche is so serious about how well their product works, they partnered with People Science to provide the Troche Tracker health assessment application that lets you monitor your progress and works with you to accomplish your wellness goals. If you are a patient, click the link below and the patient button to register for Troche Tracker. Assess your baseline health metrics and receive a free Troche sample in addition to getting preferred patient pricing on all products. If you are a clinician interested in adding Troche to your practice, click the link below and then the clinician button to register for a wholesale affiliate account or go to the link above. I hope you all enjoyed today's show and got some truly empowering knowledge out of it. You can always follow up on anything we talked about in the show notes found at our website, podofinquiry.com. If you think you might have tickled just a few neurons inside that cerebral cortex. Please spread the word to your friends and colleagues and tell them that they need to get spelunking. Also, if you can take a minute to leave a review on your podcast provider of choice, and especially Apple Podcasts, that would greatly help the show and be so appreciated, provided it's positive. And if not, then just keep your pie hole shut and stay down in that cave. Let's keep spelunking.
This podcast is designed for informational purposes only and does not constitute any medical or surgical consulting advice or imply a development of any physician-patient relationship. The opinions of guests who are featured on the show are not necessarily the opinions of Dr. Barrett or the production team. This podcast is owned solely by Barrett Medical and Surgical Media, LLC. While the show is highly oriented for physicians and healthcare providers, anyone interested in the improvement of human performance and understanding will find this a welcome goblet to sip from, or guzzle. However, no representation or warranties are made in any way whatsoever on this podcast for any products, techniques, or other things discussed. Invited guests are not vetted by the Pod of Inquiry for their qualifications and may have a direct or indirect financial interest in what they present and discuss on the show. The Pod of Inquiry disclaims any responsibility from anything taken from the show and used personally or professionally. It is a responsibility of the listener to perform their own due diligence prior to the implementation of any ideas, products, techniques, or anything talked about on the show.